So this is the first of two podcasts on the pathology of the endocrine system. In this first podcast, I'm going to have a look at the pathology of the pituitary, the adrenal cortex and medulla, and also have a very brief look at some of the multiple endocrine neoplasia syndromes. So firstly, a little word about the endocrine system. Hormones are of two types, peptides or proteins, and steroids. Peptides and proteins have their interaction and therefore mediate function via surface receptors and include insulin, growth hormone, the sex hormones, that's follicle stimulating hormone, luteinizing hormone, and ACTH. Steroids, on the other hand, have their action at nuclear receptors and stimulate hormones from cortisol, estrogen, progesterone, and testosterone. Generally, diseases of the endocrine system are due to excess production of these hormones, deficiency of these hormones, or tumours, which may cause both of the above, plus or minus a so-called mass effect. So now onto pathology of the pituitary. So the pituitary is connected by the pituitary stalk to the hypothalamus and is in two bits. The anterior pituitary, which secretes 6 factors, and the posterior, which secretes 2. So the anterior pituitary produces thyroid-stimulating hormone under the control of hypothalamic TRH, prolactin under negative control of dopamine, ACTH or adrenocorticotrophin hormone under the control of CRH, growth hormone under the control of growth hormone-releasing hormone, and the sex hormones, that's FSH and LH. In the posterior pituitary, oxytocin and ADH are secreted. However, these are synthesized in the hypothalamus and passed down along nerve axons to the point of release. Symptoms of pathology in the pituitary, or pathologies, can be due to excess production of these hormones, deficiency of these hormones, or a local mass effect because of something in the pituitary itself. The most common disease of the anterior pituitary is the pituitary adenoma, which may actually cause all of the above effects. Most, however, are non-functional and remain very small and therefore never come to clinical attention. Functional adenomas comprise 10% of intracranial tumours and are classified as micro if they are less than 1 centimetre and macro if greater than 1 centimetre. They're further classified on the basis of the hormones that they produce. While it's possible that all of the anterior hormones can be produced, the most common ones are prolactin, growth hormone, and corticotrophin. The effects of these functional adenomas can be deduced because of the hormones that they produce. So prolactinomas producing prolactin cause amenorrhea and galactorrhea. Growth hormone adenomas prepubertally cause gigantism, but postpubertally cause acromegaly with characteristic facial changes, large hands and feet, excess sweating, carpal tunnel syndrome, diabetes, and an increased cardiovascular risk. And corticotroph cell adenomas cause Cushing's disease with bilateral hyperplasia of the adrenal cortices. Deficiencies of pituitary hormones usually occur because of hypopituitarism, commonly called Panhypopituitarism. Anteriorly, 3 common things can happen. There can be a non-secretory pituitary adenoma, which compresses functional tissues and leads to hypopituitarism. There can be ischemic necrosis, which is usually due to Sheehan syndrome, postpartum hemorrhage, but may also occur with any form of shock or elevated intracranial pressure, or due to destruction, such as with trauma, surgery, or irradiation. Anterior hypopituitarism syndromes result in very subtle clinical characteristics, and in children usually lead to growth failure and pituitary dwarfism, but in adults depends entirely upon which ones are deficient. There are 2 important posterior syndromes. These are cranial diabetes insipidus, characterized by reduced secretion of ADH in response to dehydration, causing polyuria, thirst, and a normovolemic hyponatremia. Causes include head trauma, neoplasia, and inflammatory disorders. In the syndrome of inappropriate ADH, there is excessive resorption of water, often with a normovolemic hyponatremia. Clinically, this can result in severe cerebral edema and associated CNS signs. Causes include ectopic secretion of ADH by malignant neoplasms, most commonly small cell carcinoma, meningitis encephalitis, or local injury to the hypothalamus or pituitary. Lastly, we said that pituitary pathology can cause local mass effects, and there are a number to be aware of here. Optic chiasm compression leads to characteristic visual field change, termed bitemporal hemianopia. If compression becomes severe enough, it may spread laterally into the cavernous sinuses and lead to diplopia, with cranial nerves 3, 4, and 6 affected. And there may also be headaches that characteristically are worse in the morning and may be associated with vomiting. So now I'm going to go on to talk about the pathology of the adrenal glands. So we can divide up the adrenal glands into two distinct parts. Working from the outside in, there's the capsule, then 80% cortex, 20% medulla. The cortex is divided into three zones: zona glomerulosa, zona fasciculata, and zona reticularis. The zona glomerulosa secretes aldosterone, which is the key mineralocorticoid of the adrenals. This occurs via activation of the renin-angiotensin-aldosterone system, usually in response to a reduction in blood volume. Aldosterone causes sodium and water conservation in the kidney. In the zona fasciculata, cortisol is produced, which is the major glucocorticoid of the adrenal, and in the zona reticularis, androgens are produced. The medulla, which, as we said, comprises 20% of the adrenals, secretes epinephrine and norepinephrine. So now I'm going to consider the pathology of the cortex. As before, we can divide the pathologies up into ones where there is hyperfunction, hypofunction, and neoplasms. So first, hyperfunction. In hyperfunction, we may have excess glucocorticoids causing Cushing's syndrome, excess aldosterone causing hyperaldosteronism, or excess androgens causing virilizing syndromes. Excess glucocorticoids can be caused by either exogenous things or endogenous things. So exogenous things would be, say, steroid administration causing gland atrophy, while endogenous things would be Cushing's disease due to an ACTH-producing adenoma and resultant cortical hyperplasia, a primary adrenal tumour, either a solitary adenoma or carcinoma, or possibly bilateral hyperplasia, and finally ectopic production, usually from a small cell carcinoma of the lung. Excess aldosterone causes hyperaldosteronism, that, as you'd expect, is associated with hypertension, but probably as you wouldn't expect, is associated with hypokalemia that occurs without edema or sodium overload. The reason behind this is fairly complicated. Excess aldosterone in Conn syndrome stimulates reabsorption of sodium and water by the distal collecting tubules and ducts of the kidney. The ECF therefore expands and blood pressure rises. However, when the extracellular fluid volume, as represented by the blood pressure, reaches a certain point, excretion of sodium and water by the kidneys resumes, despite the raised aldosterone level. This is called an escape phenomenon and is mediated by ANP, secreted by the heart in response to excess stretching. This explains why patients with Conn syndrome don't become edematous. Escape, however, does not occur at the level of the distal collecting tubules, so high aldosterone levels stimulate continued exchange of sodium for potassium, leading to a hypokalemia. Causes of hyperaldosteronism may be either primary, characterized by a reduced renin, and secondary, characterized by an increased renin. Secondary responses occur after activation of the renin-angiotensin-aldosterone system, often after reduced renal perfusion, arterial hypovolemia. Primary causes may be due to two things: an adrenal adenoma, which should be treated surgically, and bilateral adrenal hyperplasia that responds to spironolactone, an aldosterone antagonist. So, lastly, with hyperfunction of the adrenal cortex, excess androgens lead to virilizing syndromes. In causes of this, carcinomas are more common than adenomas, but the most important pathology to be aware of is congenital adrenal hyperplasia, which is a group of autosomal recessive disorders affecting enzymes involved in cortical biosynthesis. So now moving on to adrenal hypofunction, or Addison's disease. This has a very slow onset and doesn't usually present until both cortices are destroyed. Like hyperaldosteronism, Addison's disease may be primary or secondary. In primary Addison's disease, the problem lies with the adrenals themselves and may be due to an acute process such as hemorrhage, the so-called Waterson-Friedrichsen syndrome and sepsis, or due to sudden withdrawal of steroid therapy in those used to taking it chronically. Chronic primary Addison's disease can be due to TB or autoimmune adrenalitis due to T lymphocyte infiltration of the adrenals and because of an autoantibody that's been formed against 21-hydroxylase. Secondary Addison's disease may be due to a pituitary or hypothalamic lesion. The clinical presentation of Addison's disease is with skin pigmentation due to excess accumulation of MSH, postural hypotension, hyponatremia plus hyperkalemia, and 50% of patients have hypoglycemia. Investigations include random cortisol level, an ACTH stimulating test, and treatment involves replacement of the missing factors. So mineralocorticoids can be replaced with fludrocortisone, glucocorticoids with hydrocortisone. Neoplasms of the adrenal can be either adenomas or carcinomas. Most adenomas are non-functional, and carcinomas are exceedingly rare and often associated with the virilizing syndromes. So lastly in this podcast, or penultimately, I'm going to consider pathology of the adrenal medulla. The most important pathology is that of a pheochromocytoma, which is a tumour of chromaffin cells. Predictably, these tumours secrete catecholamines and therefore cause hypertension. And there's a kind of rule of tens for these tumours. 10% occur in association with MEN2, 10% are bilateral, 10% are malignant, and it's interesting to note here that the only way to prove that these cells, that an pheochromocytoma is malignant is by the presence of METs. And 10% arise from sites outside the renals, and these are called paragangliomas. Investigations include a 24-hour urine for catecholamine urinary metabolites, such as VMA, and a CT of the adrenals. Treatment involves surgery plus medical preparation with an irreversible alpha blocker, phenoxybenzamine. So lastly, I'm going to very briefly consider the MEN syndromes. These are a group of inherited diseases resulting in proliferative lesions of multiple endocrine organs. The common features here are endocrine neoplasms at a severely young age, affecting multiple organs or being multifocal in one organ, and most of them are quite aggressive. There are two types of MEN, both of which are autosomally dominant in inheritance. In MEN type 1, that's associated with the tumour suppressor MEN1 gene, there are the three Ps: parathyroid hyperplasia, aggressive insulinomas of the pancreas, and prolactin-secreting pituitary adenomas. Parathyroid hyperplasia leads to development of renal calculi. Pancreas insulinoma leads to recurrent hypoglycemia, and the pituitary-secreting tumours cause amenorrhea and galactorrhea. They are also associated with stomach ulcers in the Zollinger-Ellison syndrome. Men type 2 syndromes are caused by mutations of the RET proto-oncogenes and are of two types. In type A, there is usually and inevitably medullary carcinoma of the thyroid and pheochromocytoma. In type B, there is the absence of hyperparathyroidism usually present in A, as well as extraendocrine manifestations and ganglioneuromas. So that completes this first endocrine pathology podcast.